your class. So after the first lecture, and I think you should have access to the teaching material, the slides I used to do the lecture last time, but I didn't include any slides of the patient's photos because I don't want the patient's photo to be circulated through any media. So please do not take photos of my patients. Okay, so let me see how I can start. Okay, so let me start with case 1. I have prepared 4 cases for you today, and let's start with case 1. Case 1 is Miss Leung, 24-year-old lady who does clerical work, single. She got history of Graves' disease, treated with radioactive iodine 2 years ago. Otherwise, her past health was unremarkable. Now that she was referred to you because of secondary amenorrhea for 3 months. Okay, so let me get some of you involved in clocking this patient. Charmaine, hi, can you hear me? Charmaine? Hello, Charmaine? Okay, probably she's not around. Let me see. Gabriel? Gabriel?
Hello.
Hi, good, okay, so I want you to, imagine that, just in 1 to 2 years' time, in clinic, this is the first time in the endocrine clinic, you are in charge of this lady. You got a referral from the GP with this chief complaint of secondary amenorrhea for 3 months. So I'm Miss Leung. Okay, Gabriel, can you start asking me questions?
你好啊，梁小姐係咪啊？
係啊。
咁我係黃醫生啦，咁就翻嚟覆診你嗰個甲狀腺嘅問題，同埋亦都聽講即係你有啲月經嘅問題啦。咁首先問一下個甲狀腺嗰度咧，係而家仲有冇食緊藥㗎？
冇㗎啦，醫生話醫好咗啊嘛，我飲咗放射碘㗎啦，我而家冇事㗎啦，冇覆診㗎啦。乜唔係嘅咩，黃醫生？我嗰次醫生同我講話飲完放射碘醫好咗啦嘛，咁我咪唔覆診咯。啱唔啱㗎
？sorry， 我可唔可以睇下個 patient 嘅樣？
個 patient 嘅樣啊，係啊，你要等一陣先喎，係啊，不過係啦，差唔多樣啊，同我差唔多樣，你講睇啦。
咁就最近冇話覺得怕凍啊、怕熱啊咁樣啊？
冇。
都冇話啲大便習慣有改變啊，例如係即係便秘啊、肚屙嗰啲都冇。
冇。
咁就睇嘢都冇乜問題係嘛？
都冇啊。
咁就咁我哋就亦都即係問下你嗰個月經嘅情況啦。咁係你3個月嚟都係冇嚟過月經係咪啊？
冇喎。
即係對上一次就係3個月前啦。
係啊，大約係㗎啦。
咁而再之前有冇試過話，即係啲月經唔規律咁樣嘅？
咦，做得準㗎，係呢3個月頭唔知做咩事咧？我驚有事啊，醫生。咩事其實我係啊，黃醫生有咩事咧？
我哋要問清楚啲先知道喎。咁我亦都問下，即係以前咧，你嘅月經係即係
個個月都嚟㗎，好準㗎。
即係個週期係幾多日至幾多日？1
個月到嚟一次咯，係啊。
咁啊嚟幾多日㗎？會即係留
1個禮拜啦，幾日啦？有咩關係咧？
亦都想問下，即係突然之間停啊，抑或係
咁咪冇嚟3個月咯，就係。
再之前咧嗰啲一路都好準嘅，即係唔係話要疏啊咁樣。
黃醫生，你問咗㗎啦喎，你又再問？
咁亦都問下你啲即係唔好介意啲私人少少嘅嘢啦。咁啊想問你有冇即係話有性行為啊嗰啲㗎？
冇，我唔會懷孕㗎，係啊。我男朋友唔喺香港啊，係啊，我男朋友唔喺香港，唔使擔心呢樣嘢，醫生。
係。咁都問下咧，會唔會話即係最近有一啲成日覺得即係譬如陰道啊會乾燥啊咁樣嘅，或者
有咩關係啊，黃醫生？
因為
你問呢個
有
問
時
題同我呢個月經嗰度有關㗎？
因為有時如果係即係有啲譬如卵巢問題咧，咁就
嚇，
即係
卵巢問題會有啲咁嘅問題嘅咩？我又未聽過喎。
誒咁我哋亦都再問下，係頭先就話睇嘢冇問題嘅，咁你唔會話真係覺得側邊膊頭嗰啲會撞到嘢啊咁樣？
冇。
咁有冇話個人會咁預防咧，會唔會話有啲分泌咁樣嘅？
都有時有㗎。
咁係即係譬如幾密會有啊？
耐唔中有啦。
咁嗰啲分泌係即係一邊預防定兩邊預防咁樣？
兩邊都有㗎。
即係咁嗰啲係咩顏色㗎？嗰啲分泌物？
白白地色咯。
即係冇話即係有血色啊咁樣嘅。
冇。黃醫生，你問咗成4分幾鐘㗎啦喎。其實你知唔？其實我咩事啫嚇？究竟？
咁即係我哋都懷疑可能會有啲內分泌嘅問題咁樣啦。
我就係嚟內分泌專科睇啊嘛。咁究竟係邊方面嘅內分泌問題咧？
我哋可能都要再做啲檢查啦。咁就睇下會唔會話即係個腦下垂體方面啲荷爾蒙。
腦下垂體咁快就去到腦下垂體咩嚟㗎？黃醫生，腦下垂體？
佢係一個我哋嘅嗰啲分泌荷爾蒙嘅地方啦。咁就喺個腦嘅下邊咁樣嘅，咁就佢會分泌好多嘅荷爾蒙咁樣嘅。我哋
咁實係腦下垂有問題嘅，會唔會第啲地方有問題咧？嗬？
另一方面
Okay, so I think Gabriel, thanks for your active participation. I think I want more colleagues to be involved. So I want to give you an idea. Time is so precious. Time management is very important. You spend more than enough time, but then you still linger on the same point without touching all other important aspects to tackle this problem. And also, you jumped from history directly to investigation. What about examination? Would you like to, follow with history and examination, and then, tell us more about, other, differential diagnosis? And maybe I pass it to Jane. Hello, Jane. Are you here with us? Hello, Jane. Hello, Jane. Okay, so she's not around. Dana, are you with us?
Hi.
Hi, Dana. Okay, good. Okay, so your colleagues, I gave him, a few minutes to give him an idea that in our end of year, exam, the final MB, and then you have, OSCE, 10 minutes, and then we expect you 7 to 8 minutes. You're able to take history together with examination, and then to grab the time to ask as much information as possible. Okay, so this patient was referred for secondary amenorrhea. Can you tell me what exactly secondary amenorrhea means?
It's when the patient has had absence of periods for more than 3 months, but they've previously had regular periods.
Okay. So I think that's very important to know what's meant by normal before you can appreciate what's meant by abnormal. And even female patient, they may have irregular periods in menarche, so it's difficult, for them to know what's meant by normal. So you are very important to let them know what's meant by normal, and also define clearly what's meant by primary and secondary. So this patient has secondary amenorrhea. That means she has menarche before, and then now that she got menstrual problem. And also your colleague, this patient also got the only bit of past history is Graves' disease, okay? And the patient told you that she's cured. No need for long-term follow-up. What do you think?
I think we should still do a thyroid examination to pick up any signs just to be safe.
Okay, so you need to correct the misconception about the patient. So, or would you tell me what's meant by Graves' disease?
It's a state of thyrotoxicosis, and it's usually caused by autoimmune destruction of the thyroid gland.
Autoimmune destruction of the thyroid gland?
And autoimmune antibodies causing a hyperthyroid state in the patient.
And that's all you know about this disease?
And it can manifest in different ways, such as Graves' ophthalmopathy or diffuse goiter, or you can ask patient whether they've experienced heat intolerance as well as amenorrhea recently.
Okay, so I think I just want to give you the stimulus to read. I don't expect like 1.5 hour tutorial to cover every topic of endocrine disease, but Graves' disease is the most common etiology for, in this locality for people with thyrotoxicosis. Is autoimmune nature, but the patient that is cured by RAI is a misconception. So you need to correct her. So for Graves' disease, of course, we want to render the patient euthyroid. We need anti-thyroid drugs. And then for patients who have relapse, and we need to discuss like alternative like ablative therapy like radioactive iodine. But radioactive iodine or surgery, both of them are ablative therapy, but doesn't mean that the patient can be lost to follow-up. In fact, they need lifelong follow-up. Why? So I'm sure we have other lecture covering thyroid, but I just want to touch on a bit. Can thyroid disease link up with amenorrhea? Yes or no?
Yes.
Yes, okay. So remember that for patients with radioactive iodine, they have chance of post-RAI hypothyroidism, or they may have relapse. And so if they have relapse, they may need a second dose. And always remember that for patients with radioactive iodine, they need lifelong follow-up, but may not that frequent compared with the thyrotoxic state, with the active Graves' disease. So we need to let the patient know you need to come back for follow-up, like regular checking of the thyroid function. And of course, if the patient got problem with the thyroid status, and then she also can have menstrual problem. Okay, so going back to this lady, okay, so I want you to remember that some basic thing you may forget, now that near the end of your medical school, but then always think about, what the cause etiology is very important. How, normal women can have their normal menstrual cycle. And so we start from the hypothalamus all the way to the pituitary, to the ovary. And so anything wrong and then can cause problem with menstrual cycle. And also one of the common cause for menstrual irregularity or even amenorrhea is polycystic ovarian syndrome. And common things come first. Okay, so I just want to touch on a bit about PCOS because there's still a lot of unknown about this syndrome, but this is a syndrome that's kind of common in women, and at least 2 out of 3 criteria are required for the diagnosis. And this include hyperandrogenism, including like clinical with hirsutism or biochemical parameters like elevated testosterone level, androgen level. And also another criteria is ovulatory dysregulation, and also with imaging morphological features of polycystic ovaries. And this is one of the common reasons for women to come to us for menstrual problem, and commonly associated with overweight or obesity. And they need lifestyle modifications, and also if they mainly have symptoms like hirsutism and then or menstrual problem, they need combined OC pills. Usually the first line drugs for the symptomatic control, but they may need additional pharmacological therapy like spironolactone. And we still not fully understand about the mechanism behind PCOS. But what we know is that there's why the PCOS women have menstrual and also the clinical symptomatology because of excess testosterone androgen circulating in the body because of the relative aromatase deficiency. And also one common very important features of them, they got hyperinsulinemia, and then they at risk of all the components of metabolic syndrome. And so I won't go into details, but then I want you to also aware that, as I point out, for the regulation of normal menstrual cycle, all the way from hypothalamus pituitary, the way down to the ovary, and the pituitary plays a very important role in regulating a number of different hormones. So if you given a chance to take the history within a few minutes, I think you need to touch on all the basic things. Don't forget what you are taught during junior medical clerkship, and very importantly about the drug history. I didn't hear anybody touch on this because this is particularly important, like whether the patient taking OC pills, herbal medicine, over-the-counter medication, etc., etc. So going back to this lady, this patient has a menarche since 12 years old, and she got regular cycle monthly and without menses for about 2 to 3 months ago. She's sexually active, although quite common these days that patients the sexual partner travel away, and then you need to ask about whether she's on contraception like pills or what kind of contraception. As I mentioned, that if the patient on any hormone that might affect your subsequent evaluation. So this patient has contraception by condom. She never had any pregnancy before, and she also had bilateral expressive gliotorrhea in the past 2 months. There's no weight change, no overt hypo or hyperthyroid symptoms, such as the patient didn't have any tremor, palpitation, or bowel habit change, etc. Her vision is stable, and occasionally she has headache. Okay, but there's no association with vomiting. Okay, so this is the patient. Okay, I think, Gabriel, you asked to see the patient. Now that the patient's back, Gabriel, 黃醫生個病返嚟啦. Okay, so Gabriel, the patient's back. Okay, would you like to comment on the facial features or what abnormalities do you detect in this patient? I know there's limitation because it's online. We don't have the real patient here. But just from this photo, what do you think?
The patient has a diffuse goiter.
How can you be so sure that she got goiter? What you can see is just a 2D photo.
There appears to be neck swelling.
Okay, so you can't just say that there's a neck swelling. You can't be so sure. Don't be overconfident, right? And then, of course, you want to ask whether, if not due to the limitation of this virtual platform to teach, you, of course, want to proceed not only by inspection, but also palpation. So although you don't have the chance to touch on the patient, you can ask additional things you want to do to confirm that this is a goiter. How will you confirm this is a goiter?
I would ask the patient to swallow and look whether the mass will move upwards, and also palpate whether it moves upwards.
Okay, so before you touch the patient, still at the stage of inspection, you ask the patient to swallow to see the neck swelling. So I think all of you agree that it's so obvious the patient got a neck swelling, okay? And then you ask the patient to swallow to see the swelling move with swallowing. And after that, you stand at the back of the patient, put your hands over the neck, and then to feel for the texture, feel for the border, feel for tenderness, feel for thrill, and then also feel for any irregularity or nodularity, okay? and then also ask the patient to swallow again to see whether it moves with swallowing. And after that, so inspection, palpation, and the next step will be percussion. So where do you percuss?
I will percuss for any retrosternal extension.
Exactly. So although sometimes apparently you can feel the lower border, but then the lower border may get all the way to the sternum. So you need to do percussion of the sternum to make sure it's resonant so that there's no retrosternal extension. And after that, you take out your stethoscope to do auscultation. So basically that's, the examination I expect you to do at least, and then to listen for any bruit. Okay. And then when you feel the neck, also you need to check for lymph node, etc. Okay. Apart from the possibly goiter in this patient. So what else do you aware in the photo?
There are also thyroid eye sign, especially there's a lid retraction and also exophthalmos. Okay,
again, you can't say this is exophthalmos because it's just, from the front. You need to stand by the side to look at the eye to see whether there's exophthalmos. So that's also the limitation. So you need to know what you can observe just by a 2D photo, and then what will you do, subsequently if you're allowed the chance to do so. So what you can do is that the patient got lid retraction, and then you like to proceed further to check for exophthalmos and also check for ophthalmoplegia. So what you do, you ask the patient to follow your fingers or all the direction, and then to see whether there's diplopia and also any evidence of ophthalmoplegia. And there's no chemosis. Important negative is also part of the examination. So what you can see from the photo, why I say chemosis is an important sign, because it's a sign of inflammation, whether there's an active thyroid eye disease. Okay, so apart from the eye exam, what else you want to do?
Also for the thyroid status, we can examine the hands for any sweaty palm or any tremor, as well as the pulse. And we can also check for any pretibial myxedema and slow relaxing reflexes.
Yes. Okay. So actually, if you have a real patient in front of you, with the greetings, when you talk to her, you can listen to her voice, whether there's hoarseness. You can shake hands with her. You can feel whether she got sweaty palms, and you want to check the pulse volume, the pulse rate, and also you want to check a complete cardiovascular examination, because you want to check whether she got any consequence, related to her thyrotoxic stay in the past. But anyway, this patient, what you found subsequent with examination confirms a diffuse smooth goiter, and she got raised ophthalmopathy, but it's not active. There's no chemosis, and there's no lead lag, and so no hand tremor. Clinically, she's not thyrotoxic. She's euthyroid, and abdominal, cardiovascular, chest examination all normal. So what's lacking? What other examination I need to do but didn't do so? Maybe I give a chance to Jane. Hello, Jane. Are you here with us? Okay, she's not around. What about Claudia? Hello, Claudia. Anything I need to do but didn't do so? 仲有啲咩未做啊？做晒放佢走未啊？
Ophthalmoplegia, like you said earlier.
No ophthalmoplegia.
I'm sorry.
Just ophthalmopathy, but no ophthalmoplegia.
Visual field.
Good. Why you're interested in the visual field? But before you test the visual field, make sure that her vision is okay. Yeah. So why? There must be a reason why you want to, ask for visual field. And I think fundal examination is also important. Why?
Is it because I'm thinking of it could be a mass? So, a pituitary mass, which could compress on the optic chiasm. Then
why do you think pituitary lesion is your top diagnosis after you got a history examination?
Because there's also
There's combination of two important symptoms, right? The two positive symptoms that are very important for this lady is secondary amenorrhea together with gynectorrhea.
Yeah.
Right? Okay. And then, what investigation will you proceed next? So this is your patient, okay?
I would do a pregnancy test.
Okay, why?
Because her amenorrhea of 3 months could potentially be.
Common things is kind of non-invasive, easily available test, and then so always ask for that, because the most common cause of secondary amenorrhea in a childbearing age lady, is pregnancy, and then patient may not aware that she's pregnant, and then ask for that. If the patient decline, we respect her decision, but then you need to offer that. It's negative. Okay, what else you would like to do?
Then I want to look at the hormone, do a hormonal assay.
What kinds of hormone you would like to ask for?
The thyroid hormones.
What kind of thyroid hormone?
TSH and free T4.
Okay, so good. So if you don't specify, if you work here, just give your TSH, because, for money, cost effectiveness consideration. But always remember, you need a paired hormone before you can say that, the patient has normal thyroid axis, because can TSH be normal and with free T4 abnormal?
Yes.
Yes, okay. If you don't ask for that, they just give you TSH normal. But what about this patient is normal, free T4, but what about if the patient got low free T4? Is it normal? Of course, no. Okay, TSH normal, free T4 low. That means, what's the diagnosis?
Oversuppression.
No. Duncan, okay, your turn.
Good morning.
Hi, Duncan. Okay, so this patient got normal TSH and normal free T4. But if I said this patient, if you don't specify, sometimes, the lab just give you a TSH with a free T4, that will be, not enough to say, assess the thyroid axis. If the patient got normal TSH but low free T4, what's the diagnosis?
Hypothyroidism.
What kind of hypothyroidism? So what's the etiology?
The thyroid gland is not responding to the TSH.
The pituitary gland is not responding to the low free T4. So what's that mean?
So it means it's a secondary hypothyroidism.
Yeah, it is central. So always remember, we need a set of feedback hormone. So can it happen in this lady? If you're kind of suspecting something wrong with the pituitary gland, of course, right?
Yes.
So therefore, always remember, we need a set of hormone to see the feedback. So for endocrinological test interpretation is simple. So we look for homeostasis, normal feedback. If the free T4 is low, then it's hypothyroid, but we want to know what's the site of lesion, what's the etiology. And then if the TSH is high, that means it's something primary in the thyroid gland. That means primary hypothyroidism, most likely related to her RAI treatment. But say if the patient got a normal TSH but low free T4, that means the TSH is not responding to the low free T4. That means something wrong high up, and then you're worrying about central hypothyroidism. Okay, so next, the patient have more hormone to come back, the gonadotrophin and the estradiol normal. So what other hormones would you like to check for this lady?
The prolactin level.
Okay, good. Okay, so now that the prolactin level is back, nearly 3 times of upper limit normal. So what else would you like to do?
I would also like to assess whether the other pituitary axis are affected.
Such as?
Such as the like the ACTH and also the growth hormone axis.
Okay, how will you assess the growth hormone axis? Will you jump to ACTH?
No, for the growth hormone.
axis by axis. So we're talking about HPA axis. You want to assess other axes. So we still remember the cartoon I showed you, the pituitary gland, secrete a number of hormones. But if you want to check the integrity of HPA axis, which hormone will you go first rather than jumping to ACTH? You know how expensive ACTH, how difficult the test to be assessed, so it's very labile, and then the blood need to be sent in ice immediately. Will you jump to a difficult test? Or
no.
Something simple, cheaper, easier?
For screening tests, we may offer the low dose methadone suppression test.
And no low dose short synaptin test. You're not. So
okay, sorry.
Endocrine is simple. So if you suspect some hyper secretion, you do suppression test. If you suspect under secretion, you do stimulation test. And the patient look Cushing to you?
Not really.
Okay. And so what you do is a low dose short synaptin test, not a suppression test. Okay. Okay. What else? You mentioned about growth hormone. Okay. So how will you assess the growth hormone axis?
The IGF-1.
Yes. The reason why we don't check growth hormone, because in adult we don't expect, usually very low and detectable because they're kind of pulsatile. And then we check more stable, and IGF-1 is the through growth hormone influence on the liver produced in a more stable manner. So we usually use IGF-1 for screening. And why is it important to screen for IGF-1 too? Because now that we're suspecting something wrong with the prolactin. Okay, so the LDS-SST is the low dose short synaptin test is adequate. Okay, with all the history exam and also the investigation on hand, we go back to revisit what can be the cause of secondary amenorrhea in this lady. So we go back whether something wrong, hypothalamus, pituitary, ovarian, all the way down. And then now that I agree that the most, kind of likely cause was something wrong with the pituitary. But mind you that don't be so simple-minded. We need to think about all the possible reasons for a high prolactin level. And the most common cause of hyperprolactinemia is drug. Okay, so therefore, I expect you to at least touch on or ask the patient about the drugs she's taking, because there's a long list of drugs that can affect the prolactin secretion. Even the patient take like a Maxilon, antiemetics before the blood taking, they can also give you a high prolactin level, and also hormones like OC pills and all this can cause a high prolactin level. And for this case, I agree that putting together with the history and with the gastatory combined with amenorrhea together with all the investigation on hand, pituitary tumor, prolactin secreting is the most likely one. And for women, usually they present early. So therefore, most of them, present to us as microadenoma. So we use 1 centimeter as the cutoff to differentiate micro versus a macroadenoma. Whereas in men, because men don't have, menstruation, and they usually present late, and therefore they allow more time for the tumor to grow, and then usually men presented to us as macroadenoma. So I think for a group of students who had the chance to join my endocrine clinic this Monday, we just saw a man with macroprolactinoma. And why I say that it's also important to check for the IGF-1 in this patient, despite the fact that she didn't look acromegalic to me. But then there's 10% chance for co-secreting tumor because prolactin and growth hormone, they come from the same germline. So therefore, always watch out for co-secretion with growth hormone. And also another possibility, non-secretory pituitary tumor because of the stalk defect. Because as you can see that from pituitary to the end organ, most of them are, through the hormone, but then it's the negative feedback. That means because most of the time, most women don't need prolactin secretion unless they are lactating the baby. So therefore, if there's a stalk defect due to a big tumor, non-secretory pituitary macroadenoma, there's a possibility that also the prolactin may be usually borderline high in most cases. And also in certain situations like hypothalamic lesions or any, hypothalamic, insult, and then they can also cause hyperprolactinemia. And this patient, only the bit of background history, her Graves' disease. And then, as I mentioned, she can suffer from post-ARIA hypothyroidism. And for primary hypothyroidism, TRH can stimulate the release of prolactin, and therefore something that you might also want to, rule out with the lab test for her. And if you work in this hospital, you don't need to worry about that because our ChemPath colleague will help us to kind of wash the specimen to rule out the possibility of macroprolactinemia. So there's a possibility that prolactin, combined with IgG and form a complex which is non-biological, active. But then in some outside lab, if the patient got a report just a high prolactin level, particularly without any symptoms, and then make sure that you double check with this diagnosis in mind, macroprolactinemia. Ask the lab to double check for that to wash the specimen, and so. Any stress basically can also cause high prolactin level. So if the patient got a seizure, and then prolactin can be shot up, and also if the patient got renal impairment because it reduced clearance of the prolactin in the blood, and then also can cause a high prolactin level. If you rule out everything, you can label patient as idiopathic. Okay, so this patient, I think all of you agree that we need to proceed to imaging to check whether she got a pituitary tumor. But I would tell you that we don't jump to that. Okay, we go by history exam and biochemical findings before we do imaging, because there's a possibility of now that we have increasing referral for patients with pituitary incidentalloma. But then with this patient, with the history exam, with all the investigation, all putting together, now that we have a reason for us to look for the pituitary gland MRI, and then we showed a microadenoma. Okay, so diagnosis for this lady. Okay, putting together, this is a lady with hyperprolactinemia secondary to prolactin-secreting pituitary microadenoma. Okay, so let me ask Dr. Wong to come back. Okay, Gabriel, you're back again. Gabriel,喺咪度？Gabriel，OK，阿黃醫生，我係阿梁小姐，我翻嚟睇報告啦，係啊，你可唔可以話俾我聽我咩事啊？
係咁我哋之前就幫你做咗個磁力共振啦，咁就揾到有一個即係好似上次咁講腦下垂體嗰度咧有一個瘤咁樣。
你真係勁啦！一係開波就已經知道係啦，係啊，果然係喎。咁我點醫啊，黃醫生？
咁嗱，首先就呢一隻咧瘤咧就係良性嘅，所以唔使擔心。咁咧就
真係你咁肯定100% 良性？
係啊，即係呢隻瘤係係良性嘅，咁佢就係會分泌一啲，但係佢即係佢會導致你啲症狀嘅原因係佢會分泌一隻叫做催乳素嘅荷爾蒙啦，咁就會即係令到即係影響到你啲經期同埋即係啲預防嘅分泌咁樣嘅，咁就我哋通常治療方法咧，咁我哋可以俾啲藥你啦，咁就會即係可以撳翻低呢隻催乳素咁樣。
咁俾咩藥我食啊？因為我扭喎，我驚喎，醫生我都係覺得要切咗佢好啲啊嚇。不如你俾我睇外科醫生，我切咗佢啦，好唔好啊？
其實通常咧就因為手術咧，其實都有翻咁上下風險啦。咁即係譬如切咗個瘤咧，都會影響到其他荷爾蒙啦。咁其實會影響即係有比較多嘅問題。咁但係咁你呢個瘤咧，其實又好細個啦，咁又唔會影響，即係又唔會影響到你腦部嘅其他結構咧。咁其實我哋用藥物治療咧係好有效嘅。咁就
藥有副作用㗎喎，食幾耐啊隻藥？食咩藥啊？
一隻叫做我諗住俾 bromocriptine。咁就呢隻藥就係啲副作用咧，就應該係有啲病人可能會話係咪瞓得唔好，或者係有啲
瞓得唔好？咦？會嘅咩？
唔係喎，係
你有冇朋友可以幫下你啊？醫生，黃醫生，我諗你都唔係好肯定點樣醫我，不如你揾個朋友幫你啊！阿洪醫生喺咩度？洪醫生 ，Hi hello， 係咯。洪醫生，你個同事黃醫生話俾隻藥，我好驚藥有副作用㗎。係啊，其實嗰隻藥咧有啲咩副作用啊？
嗰啲隻藥咧，佢叫做即係多巴胺受體嘅，其實係即係一個刺激個多巴胺受體嘅，咁其實就抑制你個催乳素嘅分泌嘅，咁佢係有啲副作用嘅，咁就包括係有啲人可能會有時有啲
唔使擔心 ，OK，
幻覺。
No worry. I want you to remember that when you make a diagnosis, you want to give treatment, and then when you give treatment, and then you need to know the pros and cons. That's not uncommon. Patient will ask, "What's the side effect?" Okay, and then you need to know. Okay, of course. First, have the indication, but then step back, think about the contraindication or precaution. Okay, so dopamine agonist, we start with bromocriptine because it's the cheapest one, but it's short acting, and it's not without side effect. There's common side effect including gastrointestinal upset, and also the blood pressure may drop a little bit, and then patient may have postural dizziness. And therefore, we usually recommend low dose, start at bedtime, together with some food to alleviate, to reduce the chance of side effect. And why we have a better preparation cabergoline. Cabergoline we give like once to twice per week because it's a low release, and then that means the side effect will be much lower and also high efficacy, especially for patients with macro polytinoma. We may want a better efficacy, or if sometimes we have a patient with giant polytinoma, and then we want a high efficacy. The reason why we won't start with it because it's much more expensive. Usually the patient will ask, how long do I need to put on these drugs? And then you need to discuss with the patient the treatment plan. And we usually give the patient treatment at least for 2 years or more. It depends. If the patient, like this index case with a small tumor with a micropolytinoma, and then we let the patient know that once you start the drugs, we expect the resolution of the symptoms, and then you start to stop to have gatoria. Also, you start to have menses come back, and then that means your fertility will come back. So sometimes when a patient present to us because of infertility, so when the patient start to have, normalization of the prolactin level, usually within very short period. And the reason also why I put this as a first case to tell you, because among all the pituitary tumor, prolactinoma is the tumor that medical treatment is the first line. Okay, for other like acromegaly, growth hormone secreting, or ACTH secreting Cushing's disease, we give medications while waiting for surgical intervention, where a surgery like for acromegaly, for Cushing's disease, the surgeries we aim for cure. But then with a polytinoma, dopamine agonist can have a cure, but we need to let the patient know that they need to stay on the drugs for at least 2 years or more, because the tumor will shrink, decrease in size, or even disappear if they're responsive. And there's normalization of the laboratory result together with resolution of symptoms. And also the patient, like this lady, she may want to have baby, childbearing, family planning. You need to let the patient know that there's no contraindication for pregnancy, but then once she got pregnant, there's a very, very small chance because of the hormonal change during pregnancy, and then the tumor, like especially the female sex hormone, then there's a small chance for the pituitary tumor to increase in size. And then also during pregnancy, we have no laboratory parameter to monitor, because in a normal pregnancy, we expect prolactin to increase. And once the patient got pregnant, we'll stop the dopamine agonist. And then what we need to monitor is a clinical side with a visual field examination. And also we don't recommend MRI during pregnancy. And then usually what we do is post-delivery imaging. But the chance for tumor to increase, particularly in case of a microadenoma, is very, very small. And then we don't need to increase, the anxiety of the patient. But the reason why we suggest to stop dopamine agonist, number one, although there's no teratogenic side report with this agent, but then we don't want to, do any drugs to stop the prolactin level. In terms of against what the nature would do. So usually what we do is monitor clinically, and then after the patient deliver the baby, depends on her plan, like lactation, etc. also. But usually we advise the patient probably put on dopamine agonist for like 2 years or so to make sure the tumor shrink, and then also won't go back again before she has pregnancy plan in the future. So I think I got this first case, and then I need to kind of hurry up a little bit because I think I only have, kind of less than 45 minutes for me to go through the rest of the 3 cases. So let me go through the second case. Okay, so okay, maybe I let Jeffrey. Okay, hello Jeffrey. Okay, so 洪醫生，睇下先Jeffrey，你姓洪，真係好啦，大家都同姓啊，洪醫生。係啊，我又姓洪嘅，係啊，我揸車㗎，係啊。咁我個私家醫生咧，家庭醫生咧介紹我嚟睇啦，你一定要幫我，真係呢6個月頭咧好唔掂啊，真係。你救一救我，好擔心我自己有啲隱性病啊！你可唔可以幫我睇一睇咩事啊？阿洪醫生，
我姓陳。
陳醫生啊？咦，搞錯咗，唔好意思啊。係啊，點算咧？我究竟有咩病咧？究竟
？Okay，OK， 咁頭先就聽過就係話呢6個月就係有啲減磅嘅情況啦，亦都話就係我
覺得瘦咗，我好虛好弱啊！我呢6個月，我覺得真係好唔妥當啊！唉，係咁呢6個月係咪係有系統性啊，或者有計劃咁樣去減磅嘅？你可唔可以大聲啲？我聽唔到啊！
我想問係呢6個月咧，係咪有計劃咁樣去減磅定係？
我冇㗎，我係唔知點解覺得自己好虛，我覺得自己瘦咗咯。
係，除咗話瘦咗，會唔會話有可能就係會覺得呢段時間都會攰咗，同埋就係啊，好攰啊！我淨冇晒興趣啊，同太太，我諗即係大件事，我諗我同我太太即係再係咁樣，即係唔知點算好。 咁個食慾嗰方面咧，
冇啊，完全冇興趣，乜嘢事都冇興趣，個人好攰。
OK， 咁除咗話嗰個就係即係同太太嗰方面，係都係6個月，大概係6個月裏邊就冇啦。呢半年完全冇啊，完全冇行埋啊，真係。係完全冇行埋過嘅。咁除咗話嗰個減少個性興趣之外，同埋就係嗰個有啲減磅之外，有冇話可能有其他嘅症狀？例如就係話呢段時間diuretics hypertension 係啊，我有血壓高啊！呢2年食緊藥，醫生話去水嘅嗰隻血壓藥，會唔會嗰隻藥有事咧？係，我可唔可以知道係邊一隻去水丸？我唔知㗎，私家醫生話去水㗎，係啊，又去水又去到血壓㗎，係啊。去到水又去到血壓。降我啲血壓，我啲血壓好好啊！我私家醫生話食得好好，冇問題。但係我食咗2年㗎啦噃，但係點解呢半年至開始又周身都唔舒服嘅咧？點解？係私家醫生有冇同你提過，會唔會嗰隻去水丸係一隻夾嘅去水丸，定係其他嘅去水丸？我唔知啊，我揸的士，我點識呢啲嘢啊？醫生，陳醫生係點算咧？你話係咪要換藥咧？咁有冇話朝頭早話有啲朝頭早會唔會有啲晨勃啊？冇啊，係啊，冇噶啦！呢半年乜係啊，連呢啲都冇啊，即係好大件事，所以我覺得我真係好虛，我真係有好大問題。 係，OK。咁除咗呢個之後，有冇話會唔會覺得即係身體上邊有啲症狀，例如就係話可能啲毛髮會減少咗啊，或者就係剃鬚嗰方面都會減少咗咁樣？
有啊，我剃鬚疏咗啊！呢個係啊，你講起又係即係好似呢半年，即係點講咧？成個人都慢晒咁樣，係啊，唔使點剃鬚，係啊，真係疏咗喎！你講起又係喎，係啊。
OK，咁除咗呢個之後，仲有冇話有一啲
眼都蒙埋？我覺得睇嘢都差咗，我覺得好大件事啊！
嗱，睇嘢嗰方面都差咗嘅，咁會唔會話覺得呢段時間好容易會撞到啲嘢咁樣㗎？
咁又冇撞到嘢，點樣為之撞到嘢啊？即係你講交通意外，我冇。
唔係，即係如果行路嗰陣，會唔會話左右明明有啲物件咁，好容易撞？
冇啊，
都冇嘅。好，之後Okay.
That's all you want to ask？我仲好頭痛啊，醫生，我頭痛，我頭都痛啊，點算咧？我家庭醫生就話我緊張啫，究竟係咪緊張咧？
咁頭痛嗰方面係同個血壓嗰度有冇話有關係㗎？
佢話我血壓好好喎，我冇事喎，佢話我血壓係啊。
咁會唔會話朝頭早特別頭痛多啲㗎？
日夜都頭痛啦，係啊。
長期都頭痛嘅，唔會話朝頭早痛嘅，會唔會痛醒咁樣咧？
咁又冇。
OK，好。I think you showed the answer though.
I think you need to kind of ask questions to differentiate. Everybody got headache, okay, but then how can you differentiate headache with important underlying reason versus attention headache? How will you ask questions related to to differentiate the how severe the problem is?
Okay.
Any suggestion?
Any affecting the ADL of the patient, and if the patient is sleeping.
So pain perception is difficult to be measured with your daily activity. Some patient with just very minor ache or pain, and then they can't go to work. Okay, so remember why I say it's particularly important this patient for headache is that you want to ask whether there's increased precipitated by increased pressure, because we worry about increased intracranial pressure, and then so ask whether the patient have increased headache with straining or vomiting or coughing, etc. And so I think you did ask a very good question about morning erection, because patient cannot have erection or ejaculation with his wife, but then he can do it with his mistress or other sex partners. But then if he had even no morning erection, and then you must take it very seriously. There's something organic going on, okay? Because in normal male subjects, male patients, they expect to have more normal morning erection. So examination, I didn't show the picture, but then this is a very pale, tight-looking middle-aged man, and then you check the secondary sexual characteristics, including the testicular size, pubic hair. All of them are 10 at stage 5. He's got no goiter, clinically euthyroid, no tremor, nothing wrong, and with the chest cardiovascular abdominal examination. So what should be done but have not been done?
In physical examination?
Yeah.
Check if there's any gynecomastia. We also want to check, visual acuity and visual field.
Very important to check for visual acuity and visual field in neurological examination. And this patient, I don't have a chance to show you how to do it by visual field examination by a confrontation test, but that's this gentleman got by temporal hemianopia. So at this juncture, what will you do next?
I would like to do some investigation for the hormonal profile of the patient, including the sex hormones, such as the androgen, testosterone, and prolactin.
Okay, so this patient with his GP, actually he got this blood test together with the referral letter. So prolactin within normal range, testosterone, low, and then TSH normal. Are you satisfied with this test, or what other additional tests you'd like to do?
I would also like to know the GnRH as well.
Okay, so remember that testosterone, the sex hormone, also got diurnal rhythm. So if the test is done in the late afternoon, and then you probably need to recheck it in the early morning. And also, as I said, we found the hormone abnormal. We want to know the feedback. And now that the low testosterone is confirmed with the repeated testing in the morning, and the gonadotrophin, estrogen, FSH are all within normal, what we call inappropriate normal. That means what's wrong?
So that means that it's a central hypo.
Yeah, so hypogonadotrophic hypogonadism. And also, as I said, don't just check TSH, you need to 3T4. And now that you've got a low-dose short synaphin test with the peak cortisol, 238, what do you think?
So there's also an inappropriate response to the...
So inadequate response, that means the patient has
a central hypopituitary.
You can't be sure about the central or not. I didn't give you the ACTH, but then you can see that there's inadequate cortisol response to the 1 microgram synaphin. That means this suspicious of adrenal insufficiency, but you're not sure it's central or primary or secondary, because I didn't give you the ACTH. But then with all this setting here, the most likely will be the central. Okay, so what else would you like to do?
I would like to do an MRI pituitary.
Yeah, good. But the MRI, you need to wait. And then more easily available is an X-ray. This is a skull X-ray of the patient. So what do you detect? So we need to be down to the earth. Okay. Oh, I want an MRI immediately, but then it won't happen in the reality. We need to wait. But before I have the MRI, what about the X-ray? Does it look abnormal? Is it normal or abnormal?
It's abnormal looking. There seems to be some...
Where's the abnormality?
I can try to draw.
Can you show us where? Can you tell us?
So it's near the pituitary region. Right.
Okay, so this is what we call double flooring. Okay, this is an important sign to tell us that there's enlarged cell, the cellular region. And because in normal people, it won't be so big. And then that means you don't expect this double flooring sign. Okay. Of course, we need high resolution, imaging, the MRI, and then you can see a big tumor. Okay. Macroadenoma approaching 4 centimeters. Okay. So taking together, this patient have a pituitary macroadenoma, likely non-secretory. I didn't give you the IGF-1 yet, but then it's subsequent not to be normal. And then what he had right now is that he got hypogonadotrophic hypogonadism together with adrenal insufficiency. So what will you do next?
The first line management should be a liaison with the neurosurgeon for
Good. Okay, so he definitely need, early referral or even urgent referral, because with the kind of visual field defect, the pressure effect. But then as a physician, while the patient waiting to see the surgeon, the neurosurgeon, what will you do? Maybe I ask Carol to involve in the management. Hello, Carol.
Hello.
Hi. So this patient is under your care, okay? What will you do while you send, a referral, consultation to ask your neurosurgical colleague to come and help? Will you do anything?
So maybe during the waiting of the neurosurgery, so perhaps I can add a medical treatment for the for the sex hormones.
Sex hormone? Why is it so important to start with sex hormone? What's even more important?
Maybe steroid to reduce the inflammation.
No, steroids should be given, but not to reduce the inflammation. Okay, so this patient need urgent, treatment with at least replacement dose of hydrocortisone because he got adrenal insufficiency. You don't want the patient to come back with Addisonian crisis, right? So therefore, we definitely seeing the LDSST result, we'll ask the patient to come back to give the patient replacement dose of hydrocortisone together with a steroid card and also advice on the stress dose cover. As this patient will anticipate to have surgery for the remove of the tumor, and then he need, even higher dose during surgical remove of the tumor for the stress dose cover. And why I say plus or minus androgen replacement therapy? Will the patient die without androgen replacement therapy? Yes or no? No, he won't die, okay? But then if you don't give him hydrocortisone, he can die. Okay, we always judge, the priority to give the drugs and then, get the pros and cons. Okay, so for this patient, the benefit of giving hydrocortisone is well balanced, the risk. Okay, what are the risks? The risk is that if the patient take the wrong dose, too much, and then he can have Cushing-Noy features. Of course, if you take it properly with the right dose, and then it's totally, you have no concern, worry about that. And then therefore the patient should be immediately put on hydrocortisone replacement dose. And for androgen replacement therapy, you can step back to think whether the pros and cons, including he got hypogonadotrophic hypogonadism, and then what can be the consequences? Of course, he got symptom, decreased libido and the sexual function, but then it won't kill. But then if you give the drugs, the patient give the male sex hormone. If he got a BPH or even prostate cancer, and then you didn't check for that, and then it can be a disaster for everyone. So make sure that if you consider other hormone replacement, think about the pros and cons. So this patient needs further workup, including checking the history, like LUX, urine symptoms, check the PSA, and also do prostate examination. And also you want a baseline DEXA scan because, especially in Asian Chinese population, particularly in elderly men, they're not concerned much about the sex function, but they're more concerned about the bone health. And then with hypogonadotrophic hypogonadism, and then what we need to, evaluate also as a baseline is about the bone health. So we need a DEXA scan also and a PSA, etc., to help us to guide the treatment, the plan for the patient. So there's no urgency, and then we can wait for that. But then what can be wait further is the replacement dose of hydrocortisone. Okay, so I think I still have half an hour to go for the 2 more cases. So let me go for the 3rd case. So this is a 65-year-old man presented with dizziness, vertigo, chest discomfort, and also shortness of breath on exercise. It all occurred about a month ago. Okay, so for this case, I don't think I will go into kind of details in the interest of time, but then I want you all to remember that when you tackle a patient with whatever chief complaint, you want to make sure that you won't miss all these important category like drug history, family history, social history, etc. Okay, so this gentleman actually had nothing remarkable, but the most striking abnormality is the finding of a high calcium level. Okay, so let me see. Angel, hello, Angel. Hello, Angel.
Hi.
Hi, hello. Can you hear me? Okay.
Yes.
So good. Now that we have a patient with hypercalcemia, so hypercalcemia can cause a lot of symptoms like constipation. In very high level, they can have peptic ulceration, pancreatitis, renal stones, and also when it's very severe, we usually take a cut off of 3, and then the patient can have neurological symptoms or if left untreated, they can die from that. And now that we don't have a lot of cases to have very high level for a long time to have cardiovascular complication, but there's something that might happen is that the shortening of QT interval. Okay, and can you tell me what are the causes of hypercalcemia? What can cause somebody with high calcium level in the blood?
It could be like a parathyroid problem.
So when you are at a loss, not knowing what can cause it, think about what are the hormones that regulate the calcium metabolism in our body. So of course, this is an endocrine tutorial. Okay, of course, we are talking about hormones. So tell me about, apart from PTH, what other hormones, in our body can regulate calcium metabolism?
Like calcitonin and calcitriol.
Okay, the main hormones are PTH and vitamin D. So, and calcitonin do fine tuning. And I agree that, you either use PTH as the way to differentiate, kind of categorize, help you to remember the different causes, because the one of the most common causes these days is primary hyperparathyroidism. It all depends where you pick up a patient with high calcium level. If you pick up the patient in an ambulatory OPD outpatient setting, they're well walking around, in just incidental finding of high calcium level, the higher likelihood that you'll pick a patient due to PTH-mediated primary hyperparathyroidism. However, if you have a consult in the ward, that patient's sick and ill and then with high calcium level, there's high chance for you to pick up a PTH-independent malignancy-related cause of hypercalcemia. So apart from, if you divide the cause into PTH-related and PTH independent, and then you'll have a different way to remember the causes. And also always remember that particularly if you have a patient who are young and have not typical age of onset, and then think about familial syndrome. So always in endocrine cases, family history is important, and so the patient can have familial causes like MEN1 or 2. And for PTH independent, as I said, vitamin D is also one of the important hormones. And I did see patients with vitamin D intoxication. They take, herbal meds, over-the-counter meds with too much, and then causing them to have hypercalcemia. And so always remember, finding a cause is very important. And don't forget the importance of ruling out medications, because like thiazide, lithium, excessive vitamin A, all this can cause hypercalcemia. And don't forget other causes like hyperthyroidism. I had a case in the endocrine clinic, an elderly lady referred to me because of hypercalcemia, and she's totally asymptomatic, but then when I feel her neck, and then I can feel a thyroid nodule, and eventually found to have a hyperthyroidism, and then due to the toxic nodular goiter, and after the thyrotoxicosis was treated, her calcium level returned to normal. So although it's not common, but it does happen, particularly in elderly lady, and then they can have a typical presentation, not like the typical way with weight loss, tremor, palpitation, etc. So so for investigation for somebody with hypercalcemia, just like other endocrine hormonal disorder, we want to pair paired hormones. So as I said, calcium can be regulated by PTH and vitamin D. So sorry, I left out for vitamin D. And then we usually need to check calcium level with paired parathyroid hormone together with vitamin D, and so to see whether the patient have a normal feedback control. And for patient with high calcium level, and then in this case with a high PTH, and even a normal PTH level is what we call inappropriate normal, we point to a primary hyperparathyroidism. So it takes some time for parathyroid hormone to come back, and then a shortcut to have some idea whether it's PTH mediated or vitamin D mediated. We can have a check of the phosphate level in the blood, because if somebody got high level of parathyroid hormone, what you expect is a high calcium and low serum phosphate, because PTH acts to to throw away the phosphate in the urine, whereas increase calcium in the blood. And where is in vitamin D excess, they will increase both calcium and to also increase phosphate level. Another thing I think you must consider and rule out is the urine calcium excretion, because in patients with primary hyperparathyroidism, we expect high calcium in the urine, because that's also one of the reasons why we need to treat them, because that will increase the possibility of renal stone. However, one category, although it's not common, is familial hypocalciuric hypercalcemia. In this kind of benign condition due to the autosomal, kind of dominant inherit due to the mutation of the tubular sensor for the calcium, they have kind of biochemical pictures very similar to primary hyperparathyroidism. But for this group patient, they have totally benign course. They have no complication, no need to treat. And then you just need to make a diagnosis and then let the patient know that they don't need any surgery or anything. Okay, so what we do next after biochemical confirmation, so that case is actually with high calcium, with high PTH, and also low phosphate, and then urine calcium also high, and then make a diagnosis of primary hyperparathyroidism. And then the next step to do is localization. And for localization, because for primary hyperparathyroidism, it can be due to adenoma or hyperplasia. And so commonly used imaging technique like ultrasound or MIBI. And also some cases we use CT scan. And this is one of the examples to tell you that with the MIBI scan that we can identify the parathyroid adenoma in the left upper loop. Then how can we decide which patient should be referred to surgeon for excision, or they should stay on medical treatment? So all symptomatic patients need to be referred to surgeon. So if they have symptoms related to her, he or she, her or his hypercalcemia problem, like constipation, like renal stone, etc., they need to be referred. Another recommendation is that if they have high calcium level, usually more than 2.8, or they have renal impairment at the beginning, because we don't want to increase the risk to have renal stone to further compromise the kidney function, they also need to be referred to surgeon. And also if the patient got osteoporosis in the beginning with bone mineral density, low T-score less than 2.5, the reason for that is that why the patient have high calcium level, because increased PTH, and then PTH kind of increased bone resorption. And then if the patient got osteoporosis in the beginning, and then with time, then it will further worsen the situation. And another criteria would be age, because the younger the patient to have, and then the longer, the bone exposed to too much PTH hormone, and then the high chance for them to develop osteoporosis in the future. And also for younger population, comparatively, the surgical risk will be lower in terms of GA and also the recovery. This is the recommendation from the Endocrine Society from the United States. And as you can see that in the past, 24-hour urine calcium is recommended, one of the criteria to assess for whether the patient should have surgery or not. Nowadays, not recommended, but I still think that for making a correct diagnosis to rule out familial hypocalcemia, which is actually not so rare, that also important, impact on the management, it should be, screened for. And I touch on a bit about osteoporosis, and I just give you a slide about, how to make a diagnosis for this kind of common problem. Cross-discipline, because patient can be admitted to orthopedic ward if they have fracture, and then they can be also under care of the geriatrician, because it's very common to have postmenopausal osteoporosis in women, and also it can be seen in the rheumatology clinic because of steroid-related side effect. So DEXA scan is the gold standard for us to make a diagnosis, and then this is one of the example of the DEXA scan of one of my patients who actually got osteopenia but not osteoporosis. And so some common site to measure would be the spine and hip. But then if you have a patient with primary hyperparathyroidism, make sure that you make the request clearly, because they will give you not only the spine and also the hip, but they will give you additional site. That's the distal 1/3 radius, which is more commonly affected for osteoporosis in patients suffer from primary hyperparathyroidism. So as you can imagine, if they have more commonly affected distal 1/3 radius, and then that means they have high chance of Colles fracture. And then we must warn the patient to avoid fall for precaution. And so for the medical treatment, if they're not a surgical candidate, if the patient refers for whatever reason, or they're waiting for surgery, as a physician, we need to provide medical treatment, and these include avoid any drugs that will exacerbate the condition. So avoid thiazide diuretics, avoid lithium, avoid volume depletion, and also avoid immobilization, and also encourage weight-bearing exercise for bone health, but then fall precaution is very important. We must ensure adequate hydration, make sure the patient have adequate fluid to minimize the risk of renal stone. And usually, patient from the lay perspective, oh, doctor tell me that I have high calcium level. I try to avoid any food rich in calcium. So there's something wrong. We actually advise the patient have a normal calcium and also normal vitamin intake, because, for example, if the patient got a parathyroid adenoma, and then the 3 other glands are normal, and then if you don't give the patient a normal calcium and vitamin D, then that will kind of have a bad effect on other normal parathyroid gland. So therefore, we usually educate the patient to stay on a normal calcium and normal vitamin D according to the patient's status. For example, if the postmenopausal women, we usually need more calcium, like 1.5 milligram per day. If a premenopausal woman or man, they need 1 milligram per day. Okay, so for medical treatment, and then sometimes even with a non-pharmacological treatment, the patient may not be under control, and then sometimes we need bisphosphonate, which help to decrease bone resorption. And I just will include some slides for you, because I think that will also be tested during your competency to be a doctor, because of course the electrolyte disturbance is quite common. Depends on how acute or how severe the development of the electrolyte disturbance. So for somebody with kind of severe hypercalcemia, there's acute management. Always remember, look for the underlying cause, and while you are on the way searching for the etiology, make sure that you must give the patient fluid, ensure adequate hydration. Close monitoring is the rule, to monitor the input, output, the urine output, and also the kidney function, electrolyte. And always after adequate rehydration first, and then you may consider furosemide. So how to get rid of the calcium through the renal tube, provide the patient have an intact kidney function. And in very severe hypercalcemia, sometimes we may need ICU support, and then usually in the ICU setting, we consider the use of calcitonin. We don't give it a routine because of the risk of tachyphylaxis, because of the receptor downregulation. So it can be only given within 2 days, 48 hours, and we reserve for very severe case. And for bisphosphonate, usually the onset won't be immediate. So usually we expect the effect to be maximum about 2 to 4 days, but don't repeat within 7 days. And for some cases, particular hypercalcemia due to vitamin D intoxication, hydrocortisone may help. This is a table to summarize the different strategies that we will adopt in patients with severe hypercalcemia. And so for within a few hours, it will work, including fluid hydration is very important, and after that we can give loop diuretics. And so I just give you some kind of more detailed mechanism how these different modality of treatment. In certain cases, they're very severe. That's why I said ICU need to be consulted, because sometimes the patient need dialysis. Okay, so I think I only have 10 minutes left for the last case. So the fourth case is a 40-year-old man with headache, dizziness, and found to have high blood pressure in GP's clinic. And then the blood pressure up to 180/100. And the blood tests in the GP's clinic include the renal function, which showed hypokalemia and also renal impairment. And so the GP referred to you for further management. And what you found on history, clocking, that the patient actually had high blood pressure for 6 years when he went to see GP for the flu, but then he thought it's just a stress, and then he didn't have follow-up after that. And However, he recorded headache, dizziness for the past 6 months, intermittent, and then worse with anxiety. And then he also got a shortness of breath on exertion in the past 2 months, and also palpitation, chest discomfort, and also some non-specific muscle weakness, and also nocturia with frothy urine. And so inquiring about the past medical history, said no surgery done before, no known history of diabetes, stroke, or coronary heart disease. But then he recorded one episode of slurring of speech associated with blurring of vision 4 weeks ago, and then resolved overnight, and it's likely a TIA attack. And drug history is not on any long-term medication, no drug allergy. His family members, parents, siblings are all well without any remarkable history. He's an accountant, married with 2 children. He's a smoker. He also drinks alcohol, red wine every day, and he eating out quite often, like many Hong Kong people, except during this period of COVID-19. And he's obese with big tummy and plethoric look, round facial appearance. During the consultation, he also got similar high BP as noted in the GP's clinic. Heart sounds a bit loud, P2, first sound normal, no murmur, a bit of pitting ankle edema. And the few cross crackles, but then cleared after coughing. He got an obese abdomen with some striaria, and no hepatomegaly, no splenomegaly, no palatable kidney, no ascites, bowel sound normal, nothing abnormal, auscultation, no fluid. And on examination of the neurological system, this is important because I think we need to check for the fundi, because if somebody got long-standing hypertension, and then there will be damage to the vessel, and then this patient actually got grade 1 hypertensive retinopathy. So diagnosis, okay. So I think I want to bring up the last case to you before I end this one and a half hour lecture, is that although most patients with hypertension are essential primary hypertension, but then don't forget the possibility of seeing a patient that you need to screen for secondary hypertension. So who should be screened? Young age people, young hypertension needs to be screened, particularly in this case with hypokalemia, and also those patients with acute, very high blood pressure, hypertensive crisis, or those with severe or refractory hypertension. They also need to be treated without complication. And what possibility the patient can have, although it's an endocrine lecture, of course, I want you to remember to rule out endocrine causes of secondary hypertension, but don't forget there can be other causes like renal cause, like renovascular or kidney disease, or cardiac causes like coarctation of aorta. So you need to check for radiofemoral delay, on physical examination. So of course, there's a long list of endocrine causes I want you to remember, but also common things like sleep apnea or any drugs can also cause hypertension. So if this is the patient in front of you, of course, you can see that he's very obviously have a moon face with supraclavicular fat pad, and then with the purple striaria on the abdomen, and then truncal obesity. So you can see that relatively the limbs are not that obese compared to the trunk. So that signifies too much cortisol in the body, what we call potato on stick appearance, truncal obesity. And so this patient, have all these signs suggestive of too much cortisol in the body. And of course, the most common things for Cushing's syndrome will be iatrogenic. So you must dig into the drug history. And then if drug history ruled out, you must work, along the line for endogenous hypercortisolism, ACTH dependent versus ACTH independent. And of course, if there's another young hypertensive patient come to you, but then now that there's another cause that's actually due to renal artery stenosis. And now that we have another young hypertensive patient come to your clinic, and then with this chest X-ray, the diagnosis is coarctation of aorta. Okay, so I think I just got a less than 5 minutes left for my lecture. I want you to remember for patient with hypertension, you need to, think about secondary cause. Don't take it for granted. It must be primary essential hypertension. And then when you do history exam and also investigation, you need to, check for end organ damage and also for endocrine causes, common causes like primary hyperaldosteronism. We need to check the plasma renin to aldosterone ratio. So for example, if the patient in the picture I show you, and then he definitely need screen for too much cortisol, and then overnight DEX suppression test or other screening tests like 24-hour urine free cortisol or even salivary cortisol, midnight plasma cortisol can be considered. And then don't forget another important secondary cause of hypertension is the pheochromocytoma, and then you need to check for 24-hour urine for metanephrines. And as I said, you want to check for end organ damage, and then so you need to check for the ECG for like LPH and also cardiac ischemia, and you want to check X-ray look for cardiomegaly. So for the index patient, of course, you want to check for ultrasound, particularly with renal impairment, but then ultrasound also if the patient have, asymmetry. So the size of the kidney between, a significant difference, and then you need to double check for renal artery stenosis, and then you might want Doppler or even more investigation for that, and echocardiogram if there's suspicion of cardiac involvement. Why do we need to treat hypertension, no matter it's primary or secondary? Of course, for secondary hypertension, we want to find the underlying cause and treat accordingly and aim at the cure. And even for essential hypertension, we also must treat because of the potential complication, including premature cardiovascular disease, stroke, and also renal impairment. That's very important for you to remember. And after secondary cause rule out for essential hypertension, we always advise on lifestyle modifications with healthy eating, low salt diet, regular exercise, and then quit smoking, etc. And for the drug treatment of essential hypertension, of course, there's a long list of antihypertensive you can choose, but always tailor-make your regime for your patients. For example, if your patient got hypertension with concomitant diabetes, and then the first line will be ACE inhibitor or ARB, which is actually recommended by all the authority like JNC guidelines, because that will help to have vascular protection, decrease diabetic nephropathy, etc. And then if you have a patient with hypertension, but then with BPH-like symptom, of course, you want to use the alpha group, and then like doxorubicin, prazosin, etc. And so all depends on your patient's characteristics for your choice of antihypertensive. So I think that's just on time for my lecture. I want you to read more, and then there's a list of papers for you to read further if you're interested about the workup or detailed evaluation for patients with suspected secondary hypertension, like Cushing's, like primary hyperaldosteronism. So I hope I give you some insights or idea about the common endocrine cases. And so questions are welcome. So any questions from the floor? Okay. May I ask if we can give bisphosphonate for treatment of hypercalcemia? Do we routinely refer them to evaluation? Okay, so for the treatment of hypercalcemia, as I said, we usually start with the investigation, workup for the causes first. So don't give bisphosphonate before you save the urine, before you check the blood, because we will mask up with all your subsequent investigation. And after you get a diagnosis, and then you need to know what's the cause of hypercalcemia. So for example, if this hypercalcemia is due to vitamin D intoxication, and then you give bisphosphonate is of no use. And so the index case I just show you, primary hyperparathyroidism, and then of course, we evaluate whether the patient, okay. So it just remind me the time's up for this 1 hour teaching, and then, okay, so let me stop it. Okay, so we need to find out the cause before we know what's the treatment. And if the patient is justified to be given, prescribed with bisphosphonate, we don't routinely refer to dentists for evaluation, but we let the patient know the potential side effect, and then including osteonecrosis or atypical fractures, and then we just let them know that when they see dentists, they need to show the dentist that they're taking this class of drugs. And then I hope I answer your questions. So if no more questions from the floor, as I mentioned, time management is important. And then I thank you very much for joining me. And I think I still have another last lecture with you on the 4th of February in Chosay. Okay, and then I look forward to seeing you again to more cases, online case discussion. Thank you very much. Oh, okay. Somebody follow up the last questions. Let me answer the last but not the least question. May I know for pituitary macroadenoma, is surgical treatment the first line treatment, but specifically for polyadenoma, medical treatment? Okay, so if patient got pituitary macroadenoma, if this is a macropolyadenoma, dopamine agonist, medical treatment is still the first line. So I'm not sure the group of students who follow me seeing that patient with macropolyadenoma on Monday endocrine clinic, he's here to share the experience. The rationale behind is that dopamine agonist, for polyadenoma, no matter it's micro or macro adenoma, they got very good response. Most of the patients respond quickly and very well to dopamine agonists. Even with pituitary macroadenoma, with visual field involvement, with a temporal hemianopia visual field defect, they can have shrinking, decrease in size within days. Therefore, I did see a patient with macropolyadenoma, but we need to admit the patient in ward with the perimetry to document the visual field, and then start the treatment, and then they shrink this. They will have improvement within a very quick period of time. But of course, some cases, there's still possibility of a resistant case. And then in such case, if the patient not respond well to dopamine agonist, even with cabergoline, and then we need to have surgeons help surgical intervention to come in to protect the optic nerve to save the vision. So in short, for prolactin secreting pituitary tumor, no matter micro or macroadenoma, we start with dopamine agonist first. And then depends on how big the size is, what's the potential threat, like the vision, and then we decide whether we need surgical intervention or not. So different scenario. For example, if there's a lady and with pituitary macroadenoma, although it's very, very rare, because as I said, they usually present early due to the menstrual disturbance. But then if we do have a similar case of pituitary macroadenoma with prolactin secreting, and then sometimes if they plan pregnancy, they may need kind of earlier intervention, more aggressive intervention. But most cases, they actually respond very well. We can do it well with medical treatment. So I hope I answered your questions. Oh, yeah. So good questions. May I ask, can we be 100% sure polyadenoma benign? The number is no. Okay, so that's the reason why don't be overconfident. Although pituitary carcinoma is very, very, very rare, it does occur once in a blue moon. So, but then we can let the patient know that 99.99% they are benign. Don't give patient too much anxiety, but then don't be so 100% sure. It must be benign. We do have pituitary carcinoma, but it's very, very rare. Okay, so thank you very much for your questions, and thank you very much for joining me. I look forward to seeing you again in the Year of the Tiger. Okay, bye-bye.